Have you ever walked onto an oncology floor for the very first time?
Oh, it is incredibly overwhelming.
Right. You just step through those double doors, and the whole environment basically screams that the rules here are totally different.
Yeah,
You
absolutely.
hear this, like, relentless chorus of IV pump alarms just echoing down the hallway, and you glance into the rooms, and hanging on the IV poles are these highly toxic, brightly colored
Stuffed
medications.
inside those heavy protective bags. Yeah.
Exactly. It hits you like this massive wave of pure intimidation. I mean, it feels less like standard nursing and more like you are attempting to navigate a hazardous waste facility.
While trying to keep a profoundly vulnerable person alive.
Right. It is high stakes. Welcome to the Super Nurse Podcast, by the way. I want to explicitly state right at the top that this show is created by Brooke Wallace.
The one and only.
Yep. Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author. And to be totally clear, I am not Brooke
Well,
Wallace.
definitely not.
But everything we are exploring today is built directly from her bedside knowledge, her clinical notes, and her specific teaching style.
Because our mission today is really to help nursing students and new nurses bridge that massive gap between textbook theory and messy bedside reality.
Which is such an intimidating gap. I mean, knowing the textbook definition of an alkylating agent is great, but it's very different from knowing how to safely troubleshoot that specific drug when the IV tubing gets kinked at 2 in the morning.
And the pump is just screaming at you.
Right. So before we jump into the clinical details, we enthusiastically invite you to subscribe and check out the brand new comic book-based educational video on YouTube.
It's so good for visualizing this stuff.
It really is. The link is right down in the description for the channel, which is called Super Nurse Comics.
Really recommend it.
So our focus today is demystifying oncological safety protocols. We're decoding the strict rules around handling hazardous drugs, troubleshooting mechanical pumps, and aggressively managing severe patient side effects.
Basically, we want you to step up to that bedside with total confidence.
Let's start with what clinical practice calls the invisible threat. When a patient receives intravenous chemotherapy, the drug obviously enters their bloodstream.
Right, it goes systemic.
But it doesn't just vanish once it does its job on the tumor. I mean, if the liver is metabolizing it and the kidneys are clearing it, those toxic byproducts have to go somewhere.
Exactly. The patient essentially becomes a temporary biological hazard.
Wow. Okay.
Yeah, they become the primary vector for exposure.
Yeah.
Clinical guidelines give us what we call the 48-hour rule.
So the chemo is still active for 2 days.
Well, the toxic metabolites remain in the patient's system and are actively excreted for roughly 48 hours after administration.
Okay, that's a long time.
And with certain targeted therapies, that excretion window extends up to 7 days.
7 days. I think a lot of people hear like renal clearance and assume we just need to be careful with the patient's urine.
Oh no, that is a huge misconception.
But if these drugs are traveling systemically, they have to be in more than just urine, right?
They are in literally everything. Urine, stool, vomit, saliva, sweat, and even semen and vaginal fluids.
Wait, sweat.
Yeah, so think about it. If your patient is running a fever and they're just sweating profusely through their hospital gown, those sweat-soaked bed linens are heavily contaminated with hazardous chemotherapy waste.
Man, knowing that, basic hand washing and standard room cleaning clearly aren't enough.
Not even close.
So how does a nurse handle, like, the most common route of excretion? I mean, the patient just using the bathroom.
Strict mechanical protocols are required here. So, first off, ambulatory male patients are instructed to sit down to urinate.
To eliminate splashing, I assume.
Exactly, to eliminate the possibility of splashing. But the most crucial detail for both nurses in the hospital and caregivers at home is the flushing protocol.
Okay, what's the rule?
You must double flush the toilet, and you absolutely must do it with the lid entirely closed.
I'm guessing this has to do with the physical mechanics of the flush itself.
You got it.
Like, when a toilet flushes, it doesn't just drain the water, it creates this vortex that kicks microscopic droplets into the air.
Right, that invisible plume of aerosolized droplets is the real danger.
So if the lid is up,
If that bowl contains chemometabolites, an open lid flush essentially launches a cloud of toxic aerosols directly into your breathing zone.
yeah, that is terrifying.
And it coats all the surrounding surfaces. So the closed lid just acts as a physical barrier against aerosolization.
Okay, speaking of barriers, I need to challenge a widely held assumption about PPE, or personal protective equipment.
Okay, lay it on me.
We use standard latex gloves for literally everything else in the hospital to protect ourselves against HIV, Hep C, all sorts of bloodborne pathogens.
Right, standard practice.
So why wouldn't they work for chemo? I mean, liquid is liquid, right? Why is there a mandate for specialized PPE?
It actually comes down to molecular size and permeability. So think of a virus like HIV as a giant beach ball trying to pass through a chain link fence.
Okay. The standard latex glove is the chain link fence.
Exactly. The virus is simply too large to fit through the microscopic pores in the latex. It bounces off.
But chemotherapy drugs are different.
Very. They are small molecule, often lipid-soluble chemical agents. To those molecules, the latex glove isn't a solid barrier at all.
It's just a net.
It's a wide-open net. The drug molecules slip right through the latex like grains of sand through that chain link fence.
Meaning the drug would seep directly through the glove and absorb right into the nurse's skin.
Precisely. Which is why clinical guidelines mandate specialized nitrile gloves.
Because nitrile is denser.
Yeah, it's a much denser synthetic rubber polymer that effectively blocks those tiny chemical molecules. In many oncology settings, nurses actually double glove with nitrile.
Double glove over the gown, right?
Yep, over a thick, impermeable gown cuff. And remember, this applies to solid medications too.
Like oral chemo pills.
Yes, if you're administering oral chemotherapy pills, you never, ever touch them with your bare hands.
Because of the moisture on your fingers?
Right. The moisture on your skin can degrade the pill coating instantly, allowing your skin to absorb the drug right there on the spot.
Wow. Okay, so that invisible threat in the bathroom isn't the only environmental hazard, though.
Not at all.
Because we are dealing with highly concentrated bags of raw, unmetabolized drugs hanging right there in the room on the IV pole.
The pure stuff.
Yeah. So if a bag drops or a line snags and rips, my instinct as a nurse is to grab a handful of paper towels and some hospital-grade bleach wipes and just scrub it.
And that instinct would turn a local spill into a massive contamination event.
Really? Just from using bleach wipes?
Yeah, because standard bleach wipes might kill bacteria, but they do not neutralize complex chemical agents.
Well, it just pushes it around.
Exactly. Wiping it with a standard towel often just smears the toxin over a way larger surface area. You have to immediately escalate to a code yellow.
And grab a specialized chemotherapy spill kit.
Yes, the yellow kit.
Let's look at the chemistry and mechanics of that spill kit. What is actually in it that makes it so different from standard hospital cleaning supplies?
Well, the physical barrier comes first. The kit includes 2 pairs of thick nitrile gloves, an impermeable gown, a particulate mask, and protective splash goggles.
Okay, so you suit up fully.
You do all of that before you even step near the fluid. Then, to handle the liquid itself, the kit uses specialized, highly absorbent polymer pads.
To soak it up.
Well, they instantly gel the liquid, preventing it from running or splashing further. But interestingly, many kits also include specialized dish soap or a specific chemical detergent.
Wait, dish soap? Like literal dish soap. Does it have to do with the lipid-soluble nature of the drugs we just talked about?
You nailed it. Many chemotherapy agents have lipid or fat-based components to help them enter human cells.
Oh, I see.
So just like dish soap breaks down grease on a dirty frying pan using surfactants, it breaks down the lipid structure of the chemotherapy drug.
Lifting it off the floor so it can be wiped up safely? That makes total sense.
It's all chemistry.
So once you've absorbed the spill, you are left with this pile of highly toxic soaked pads and contaminated gloves.
A very dangerous pile, yes.
You obviously aren't tossing these in the regular trash, but you wouldn't put them in the standard red biohazard bags either.
Never. Because the red biohazard bags go to an autoclave.
And an autoclave just uses pressurized steam, right?
Right, steam to kill infectious bacteria and viruses.
Yeah.
But steam sterilization does absolutely nothing to destroy a stable chemotherapy molecule.
It would probably just heat it up.
Yeah, it wouldn't neutralize it. All contaminated materials must be double-bagged in heavy-duty, impervious plastic and placed into designated yellow chemotherapy waste containers.
Where do the yellow bins go?
Those bins are sent to a facility for extreme high-heat incineration. It is literally the only way to physically break the chemical bonds of the drug and render it harmless.
Man. So what happens if a nurse makes a mistake and the chemo splashes directly onto their skin? I assume wiping it off isn't enough.
Not at all. Clinical protocols dictate washing the area with soap and water, for a full 5 minutes.
5 whole minutes.
Or flushing the eyes for 10 to 15 minutes if it splashes there.
Just continuously flushing.
Yeah, you need continuous running water to physically dilute and flush the chemical away from the microscopic pores of your skin before it can absorb systemically.
You know, you might be listening to this thinking, I'm busy, my other patient is crashing down the hall, I just need to clean this up fast.
Yeah.
It can totally feel like bureaucratic red tape.
It does feel like that sometimes, especially at 3 a.m.
But this is really about the biological effects of microexposures over a 20-year career, isn't it?
Exactly. If a nurse cuts corners and absorbs microscopic amounts of systemic toxins day after day, those agents do exactly what they are designed to do.
Which is target and alter DNA.
Yep. Over a long career, repeated occupational exposure can subtly cross-link and mutate the nurse's own cellular DNA, significantly raising their risk of secondary malignancies.
That is so sobering.
It is. You wear that heavy yellow armor to protect your own cellular integrity.
Okay, so containing leaks when they happen is obviously critical. But to truly protect the environment and the patient, we have to look at the machines causing the leaks in the first place.
With electronic IV pumps.
Yes, because these drugs have such a narrow therapeutic index, meaning the difference between a healing dose and a lethal dose is incredibly small, we rely on highly sensitive pumps.
And when they detect an issue, they scream.
They are so loud, and it frequently leads to alarm fatigue. Newer nurses just get overwhelmed by the overlapping noise and want to hit the silence button so they can hear themselves think.
We've all been there. But hitting silence doesn't fix the underlying mechanical failure.
Right. Experienced nurses don't just silence alarms, they interpret them.
They troubleshoot the big three alarms by working backward from the machine like a detective.
Okay, let's break down the physics of the big three, starting with the downstream occlusion alarm.
Okay, downstream.
If I'm thinking about the flow of the IV line, downstream has to mean the blockage is happening between the pump and the patient.
Exactly.
So the machine is trying to push fluid, but it's hitting a brick wall.
That is the exact mechanical reality. The pump measures pressure resistance. If that resistance spikes, the pump stops.
So where does the detective work start?
Your detective work starts at the machine and moves down the plastic tubing toward the patient's vein. You are looking for physical resistance.
Like a kinked tube.
Yeah. Did the patient roll over and kink the tube? Did a clamp get left closed? You also have to assess the IV insertion site itself.
Oh, like if the dressing is taped so tightly that it's compressing the vein?
Exactly. Or, most dangerously, is the line clotted off inside the vessel.
Right, that makes sense. So an upstream occlusion alarm must be the exact opposite.
Thought on.
The pump is attempting to pull fluid from the bag, but it's starving for fluid. Like, it's pulling, but nothing is there.
The machine is basically pulling against a vacuum.
Yeah.
This is happening above the pump. The most common culprit is just an empty IV bag. Easy fix.
But if you are administering a drug from a rigid glass bottle, which is common for certain chemo drugs that react with plastic, the tiny vent cap on the tubing might be closed.
And why is that vent cap so important?
Well, if no air can enter the glass bottle to replace the fluid leaving it, it creates a powerful vacuum. The fluid physically cannot flow down, and the pump starves.
Wow. Okay, so the third alarm is the one that terrifies everyone, right? Air in line.
Oh yeah, the dreaded air in line.
We all know injecting a large air embolus into a patient's bloodstream can be fatal. But there is a very specific dangerous habit some nurses develop when trying to prevent this alarm.
They try to burp the IV bag.
Right. Explain why that's bad.
Well, it seems logical at first glance. A nurse sees excess air in a semi-rigid IV bag, so they turn it upside down and squeeze the air out, thinking they're preventing bubbles.
That sounds like a good idea.
But by doing that, they force the plastic bag into an unnatural compressed shape. As the fluid drips out, the stiff plastic tries to return to its original shape. Oh, and that actively creates a negative pressure vacuum inside the bag.
Yes, and that vacuum aggressively pulls air straight down the tubing.
Causing the exact massive air bubble they were trying to prevent.
Exactly. It's totally counterproductive. The correct clinical practice is to prime your tubing very slowly, letting gravity gently pull the fluid down.
And you need to ensure your drip chamber is at least half full to act as a buffer.
Yeah, that's crucial.
Now, there's also a fascinating aspect of physical chemistry here regarding the temperature of the IV fluids.
Gas solubility.
Right. What happens if your IV fluids or chemo bags were stored in a clinical refrigerator?
You must let them reach room temperature before priming. According to Henry's law, cold liquids can hold a high amount of dissolved gas.
Okay, so the gas is just trapped in the cold fluid.
Yes. But as that cold fluid travels down the tubing and warms up to the ambient room temperature, it can no longer hold that gas.
So it just releases it.
The gas physically outgasses, forming hundreds of tiny microbubbles inside the line that will trip the alarm every single time.
That is wild. I mean, we've covered all these loud screaming alarms, but the most terrifying scenario isn't when the pump is making noise.
No, it's not.
The silent threat is when the mechanical pump is failing, but it doesn't alarm at all.
This is a huge issue, because inside that pump is a highly calibrated stepper motor pushing small rollers against the tubing to deliver exact microliters of fluid.
Right, highly precise.
But over thousands of hours of clinical use, those internal mechanical rollers physically wear down. They lose their precision.
So the pump gets confused.
A pump might begin underdosing or overdosing the patient by 4 or 5% without ever triggering a pressure alarm.
And a 5% error on a bag of basic saline doesn't matter. But a 5% overdose on a highly toxic vesicant chemotherapy drug.
That could destroy a patient's internal organs.
Man.
Which reinforces the absolute bedrock of bedside nursing. You monitor the human, not the machine.
You cannot rely blindly on the digital readout.
Never. You must perform meticulous baseline vital signs before you press start and take frequent mid-infusion vitals while the drug is running.
You are actively hunting for the early physiological signs of a dosing error. Right.
Or an adverse reaction. You're looking for sudden shifts in blood pressure, a spiking heart rate, or a change in respiratory status.
Because monitoring the physical equipment is only half the battle. The other half is anticipating what is happening inside the human being attached to that pump.
Their body is undergoing intense physiological warfare.
Which requires a fundamental shift from reactive nursing to proactive nursing. I mean, the biggest amateur mistake you can make on an oncology floor is waiting for the patient to complain before you intervene.
Absolutely. If you wait for the symptom to appear, you are already behind the curve.
And with chemotherapy, catching up is nearly impossible.
Good luck trying.
Let's look at the gastrointestinal system because nausea is the classic side effect. If a patient presses the call bell and says, "I feel like I'm going to throw up," we've basically failed.
We have. Because nausea isn't just an upset stomach here. It is a complex neurological cascade.
How does that work in the brain?
Toxins in the blood trigger the chemoreceptor trigger zone, or the CTZ, which sits in the medulla of the brain. Once that neurological vomiting cycle locks in, it is incredibly difficult to break.
So what's the proactive approach?
The gold standard of proactive bedside care is administering a powerful antiemetic, specifically a 5-HT3 receptor antagonist like ondansetron or Zofran.
And timing is everything here, right?
Yes, you give it 30 to 60 minutes before the chemotherapy infusion even begins.
I always picture Zofran acting like a localized missile defense system.
I like that analogy.
Like the chemotherapy molecules are the missiles traveling through the bloodstream, heading straight for those 5-HT3 receptors in the brain. But the Zofran gets there first, binds to the receptors, and jams the lock.
Exactly.
So when the chemo arrives, it physically can't trigger the nausea response.
That is a perfect visualization of competitive antagonism.
Yeah.
You have to jam the lock before the threat arrives.
What about stomatitis or mucositis? This is where the rapidly dividing cells of the mucous membranes in the mouth are destroyed, right?
Right, causing severe ulcerated inflammation. Because chemotherapy indiscriminately attacks any rapidly dividing cell, the mucous membranes are heavily damaged.
So the mouth basically just becomes raw, open tissue.
It is agonizing for the patient. It prevents them from eating or even drinking water. Clinical guidelines require instructing patients to use prescribed viscous lidocaine.
To numb it.
Yeah, they swish it around to physically numb the exposed nerve endings so they can actually tolerate swallowing.
And we have to explicitly warn them about over-the-counter mouthwashes, don't we?
Oh, absolutely. You must strictly advise patients to avoid any alcohol-based or glycerin-based mouthwashes like standard Listerine.
Why is that so bad?
Alcohol is a severe dissecant. It aggressively dries out tissue. Putting an alcohol-based mouthwash on raw, ulcerated gums will feel like a literal chemical burn.
Oh, that sounds awful.
It causes excruciating pain and actually delays the cellular healing process.
Okay, let's touch on the skin, specifically for patients undergoing external beam radiation therapy.
So irradiated skin is essentially suffering from a localized, deep tissue burn.
Yeah.
It becomes red, dry, flaky, and highly vulnerable to break down.
So what's the bedside instruction for that?
It must be incredibly strict. Patients cannot apply everyday talcum powders, commercial deodorants, or perfumed lotions to the irradiated area.
Because the chemicals will react.
Right. The chemicals in those products can cause severe secondary skin reactions. Furthermore, they must wear loose-fitting, soft cotton clothing
Just to avoid rubbing it.
to completely eliminate mechanical friction over the vulnerable site. Yes.
Okay, I want to pose a clinical scenario that frequently trips up newer nurses.
Let's hear it.
I'm taking my patient's vitals, and their temperature is 100.4 degrees Fahrenheit, which is exactly 38 degrees Celsius.
Okay, 100.4.
In my everyday life, if I have a 100.4 fever, I feel slightly warm, I take a Tylenol, and I go to sleep. It is incredibly mild.
Totally.
But on an oncology floor, a 100.4 fever is treated like a 5-alarm fire. Why?
You are hitting on one of the most critical concepts in oncology, the neutropenic siren.
The neutropenic siren. Explain that.
Chemotherapy causes profound bone marrow suppression, known as myelosuppression. The bone marrow physically stops producing neutrophils, which are the white blood cells responsible for fighting off bacterial invasions.
So the patient has absolutely no immune system. And if they have no white blood cells, they can't mount a normal inflammatory response.
Exactly. We rely on inflammation to show us where an infection is, right? Redness, severe swelling, localized pain, or a raging high fever.
Right.
But those symptoms are caused by white blood cells rushing to the site of infection. Without white blood cells, there is no localized warning sign.
Wow, so the body can't sound the alarm.
To make matters worse, these patients are frequently prescribed high-dose corticosteroids to manage other chemo side effects.
And steroids are massive anti-inflammatories. They suppress the release of cytokines.
So the steroids are actively masking whatever faint inflammatory signal the body might still be trying to send. By the time that patient's temperature creeps up to a supposedly mild 100.4 degrees, it means a bacterial pathogen hasn't just entered their body.
It has likely flooded their entire bloodstream unchecked.
Exactly. That mild fever is the only systemic siren left, indicating life-threatening sepsis.
So you don't just give them a Tylenol and a warm blanket.
No, you immediately draw blood cultures to identify the pathogen and start hanging broad-spectrum IV antibiotics.
It really is the definition of clinical judgment, knowing why a seemingly small number is actually a massive physiological warning sign.
Spot on. Now, before we conclude, we have to address a very rare but incredibly dangerous environmental hazard.
Okay, what is it?
A dislodged internal radiation pellet.
Ah, right. Internal radiation, or brachytherapy. That involves placing physical radioactive isotopes directly into or right next to a tumor?
Yes. And if a patient moves unexpectedly and one of those radioactive pellets accidentally dislodges and falls onto the bed linens or the floor,
The protocol is absolute, right?
it is absolute. You never, ever touch that pellet with your bare hands, and you do not touch it with gloved hands.
Because gloves do not stop gamma radiation.
Exactly. You have to rely on the physics of radiation safety. Time, distance, and shielding.
So how do you pick it up?
The inverse square law dictates that doubling your distance from a radiation source drops your exposure by a factor of 4. So you immediately use long-handled metal forceps to pick up the pellet.
Just maximizing the physical distance between the isotope and your body.
Exactly. You place it directly into a designated thick lead-lined container that is kept in the patient's room, and you immediately call the nuclear medicine department.
Or the radiation safety officer.
Yes, right away.
Wow. Okay, let's synthesize the crucial lessons we've explored today. First, we prove that oncological safety extends far beyond the IV pole. We must respect the 48-hour excretion rule.
Yes, because chemotherapy is a systemic chemical hazard that exits the body in all fluids.
Which demands strict environmental protocols like double flushing with the lid down and understanding why dense nitrile polymers succeed where standard latex fails.
Second, we learned to decode mechanical 5E pump alarms by working backward from the machine, understanding the physics of fluid dynamics.
And recognizing that the silent threat of a miscalibrated stepper motor requires us to constantly monitor the patient's physiological vitals.
Finally, we broke down the shift from reactive to proactive nursing.
We jam the 5-HT3 receptors before the nausea triggers. We protect irradiated skin from chemical and mechanical friction. And we understand the profound danger of myelosuppression.
Because the bedside meaning of everything we've discussed is that oncology nursing isn't just about memorizing a list of complex pharmacology terms.
It is about total situational awareness.
It is about protecting your own cellular DNA from toxic exposure, protecting the hospital environment, and above all, protecting a highly vulnerable human being.
If you retain nothing else from today, remember the golden rule of oncology vitals. In a neutropenic patient, treat a 100.4 degree Fahrenheit fever as a code level emergency.
Always.
I want to leave you with one final provocative thought to mull over. We have spent this entire time talking about highly controlled hospital environments, but the future of oncology is rapidly shifting.
It really is changing fast.
Advanced treatments are moving away from traditional hospital IV infusions and heavily toward oral home care regimens and targeted therapies.
Which is great for the patient's comfort, but
But the immense burden of hazardous materials, safety managing toxic bodily waste, handling complex spill kits, preventing cross-contamination is shifting directly onto the shoulders of the patient's family members in their own living rooms.
that is a massive responsibility.
It is. How is nursing education going to adapt to train spouses, partners, and even children to act as makeshift hazardous materials handlers?
It fundamentally forces the oncology nurse to evolve from being just a bedside clinical caregiver to becoming an intensive, highly skilled community educator.
It changes the entire paradigm of care. Well, remember to head over to YouTube, hit the like button, subscribe, and leave a comment on the Super Nurse Comics video. Let us know how visualizing these concepts helps you connect the dots.
Yes, please do.
And finally, invite yourself to visit supernurse.ai for incredible resources to help you bridge that gap and become the super nurse you were born to be.
Keep trusting your clinical judgment, look for the subtle clues, and stay safe at the bedside.
Until next time, remember that sometimes the most dangerous alarm is the one that isn't ringing at all.